Okay, so good morning or yes, good evening. So my name is Valence, and I was just going to tell you a bit about my experience in Cairo. Now, I know a lot of you are probably waiting for a long time to do this exam because I did actually had gotten a space to do the exam in 2020 in Glasgow. Then, of course, because of COVID, everything got delayed, and I had no idea when I'd be able to actually do it. And then when they resumed their exams, it's a space in Cairo, thankfully. So just telling you a bit about it. Now, this is going to be interactive. It's requested by Professor Musami. So I'm going to tell you a bit about the exam experience overall, but I'm also going to show you the kind of questions that I got so that you know what to expect. So this is me morning of my oral exam, which was at a hotel. I'm trying to remember which hotel it was, but it doesn't really matter. Um, so I go into the hall, and the first thing I have is neuroophthalmology and medicine in the oral exam. And they show me a picture, something like this, of a patient that has obviously a hemifacial spasm. And they ask me, how would you manage this patient? Um, so anyone want to give an answer? I want you guys to be shy. Hello? Okay, no one wants to give an answer? Wayne,
Um,
think that. Hello?
yes, yeah, yes, Dr. Balance. This is a, I mean, um, you want us to tell the management of hemifacial spasm?
Yes, please.
Yeah. Hemifacial spasm is something that we would encounter in patients who are in their, say, about their in their 60s, and it is basically caused by basically it's caused by the spasm of the orbicularis oculi on one side, and it is usually idiopathic, but yeah, we would ideally like to do neuroimaging to make sure that there is nothing neurological that could be contributing to this condition. And treatment would be depending upon how severe the patient's condition is and how much of difficulty the patient is encountering in their day-to-day activities. Um, the most commonly given treatment is botulinum toxin injection. I can't remember the I mean, yeah. We would inject it subcutaneously around the into the orbicularis oculi. That would cause temporary paralysis of the orbicularis oculi. And usually the effect wanes off within a period of, say, 2 or 3 months. And we would have to repeat it as soon as the symptoms come back again.
Oh, that's great. So the way that the exam goes is I feel like they have some sort of words that they're looking for you to say. And once you say that word, then they stop you and then they ask you another question. So the moment I mentioned Botox, they asked me what the contraindications were. Do you know any contraindications to use in Botox? Because I didn't really know the answer to the question. The only thing that I came up with in the exam was if you were allergic to botulinum toxin.
Sure. That makes sense. I can't really think of anything off the top of my head either.
Yeah, so they're asked. I feel like she was kind of prodding me for any condition where the patient is having weakness, sort of a thing. And I eventually said another thing that apparently was also a contraindication, which is myasthenia gravis. I didn't know that. And it's also, I think, relatively contraindicated in pregnancy because it's a class C drug, so there isn't enough evidence as to whether it's safe or not. So generally it would be avoided in pregnancy as well. But I I had no clue how to answer the question. Um, okay, so then after that, now they show you these pictures on these glossy cards, and I find that the pictures are often not very good. But the next picture is something like this, where I needed to describe the picture. What do I think is the diagnosis? And then after that, they asked me about the ocular and systemic associations. So, anyone want to take this one? What do you guys think? What does this look like? I mean, not this off the internet, but it's pretty similar to the exam picture.
Actually, I'm really not sure, actually.
Okay. What
Is
was I trying
it optic
to?
disc hyperplasia with a double ring
Yeah.
sign?
Yes, exactly. It's optic disc hypoplasia. The arrows are kind of trying to show you the two rings. This ring, the smaller one, shown by the white arrow, and then a bigger one with the dark arrow. So yes, it's a double ring sign. It's optic disc hypoplasia, and I didn't really expect it in the exam, but it's what they gave me. So um, knowing that, what are the associations?
The ocular association is associated with microphthalmus, cataract. I think it's also aniridia. But the most dreaded systemic association is you have to rule out midbrain anomalies, especially the D. Morzier syndrome, and also hormonal problems, especially pituitary evaluation by an endocrinologist is mandatory.
Yes, exactly. So pan-hypopituitarism is also associated. All right. So then the next question, honestly, she showed me a picture that looked just like this. I described it and it looked like an optic disc pit, but I don't know if I was wrong because she was asking me what else could it be, and I really wasn't sure. It looked exactly like an optic disc pit. And I think after that, my time on the neuroophthalmology part was done. So then after that, we moved on to the medicine part. Um, so the gentleman gives me a scenario. A patient is having a seizure. I think he said like in your office, and how would you manage the patient? So here we go, medicine. How would you manage a patient in your office having a seizure? Anyone have some sort of suggestion as to what you would do in this scenario? I feel like to some degree I was a bit fortunate that seizures is one of the things that I actually looked at not that long before the exam because I thought it could have come. But how would you manage? I know it's not exactly an ophthalmology question, so I started off with, well, it's really what I learned in medical school, to assess the airway, breathing, and circulation, and to position the patient, we give them high flow oxygen, um, and you want to also, if you can, check their blood glucose level, and then you're going to want to abort the seizure if it's not stopping on its own. So the drug that I had suggested was midazolam, based on the book that I had read for medical emergencies. At the time, I knew the dose. I don't remember what the dose is now. And then he asked me what the possible causes were. So I started listing a lot of different causes, like hypoglycemia and various electrolyte disturbances. Could be a patient who has epilepsy, it could be some sort of toxin. I don't remember exactly where the hypoglycemia came, but clearly he was looking for me to say hypoglycemia at some point. And when I did, he asked how would you manage patients if they have hypoglycemia? So clearly you're going to want to give intravenous glucose if you can, but he wants to know, what if they have hypoglycemia and you cannot establish an IV line because of their seizing? And I had to think about it for a while, but my book actually saved me because apparently the answer is that you give intramuscular glucagon. So it wasn't too bad for me. And then the other questions in the medicine section were very eye related. So they didn't really give me a problem, as in thyroid eye disease and sarcoidosis, were also things that I expected to come. So wasn't so, because I was really worried about the medicine part of the exam, to be honest. All right. So then we moved on to the next station. So it had anterior segments, and they showed me a picture. Now the picture was zoomed in a lot more than this picture is, and it was showing a white ring in the cornea, but the picture quality was very poor. Honestly, this is a way better picture than the picture that they gave me, and it apparently was supposed to show a Wellesley ring. So when I eventually got to it being a Wellesley ring, then we continued. So he asked about how acanthamoeba keratitis typically presents. So anyone want to take this question?
Yes. The acanthamoeba keratitis, usually the patient has severe pain disproportionate with the clinical signs. And coming to the eye ocular findings, the eye is usually congested with dry looking, dry looking picture with presence of a ring infiltrate as well as radial keratoneuritis. Yeah, that much.
Good.
There
So
can be
you have a
limbitis.
patient. What's that?
There can be associated limbitis as well.
Yes. I think there are also some other things, like you can have pseudodendrites too. But if you have a patient who you suspect has an acanthamoeba keratitis, how can you confirm that that's what it is?
We can confirm by doing a corneal scraping. Or we can find the cysts on a KOH mount, as well as we should send it for as well as even on gram stain. And on culture, it is specific for non-nutrient agar with E. coli seeding. That is one way of confirming. If corneal scraping is also, there's another method. We can even know the cysts in the confocal microscopy. Mm,
Yeah.
Anything else?
So what are the stains for acanthamoeba? Any
Can you
specific
ask?
histological stains?
White. Calcofluor white, yeah. Calcofluor white
Yeah.
stain.
Yeah, and also quinine orange. All right, so I said all of that, and he asked me what if the corneal learning. Okay, so I actually, after he asked what if the corneal scraping is unhelpful, I suggested confocal microscopy, as he mentioned, and he said to me, "Do you have confocal microscopy available at your unit?" The answer is no. So he was saying that the answer that he had wanted. Well, can anyone hazard a guess as to what else we could do if corneal scraping is unhelpful and you don't have confocal microscopy?
Can we go for a corneal biopsy?
Exactly. So that's the answer that he was looking for. And I think we moved on. So then they showed me this picture. So it was obviously a patient who had some sort of a uveitis because there were keratotic precipitates. I think the eye looked a little bit red. And the question is the uveitis active or not? And I think the answer he was looking for is that you'd have to actually do a lamp examination to tell if the uveitis is active or not. You know, if it's a trick question. So then the next thing is in the picture that they showed me, there was also a mature cataract. So how would you manage a patient like that who has a uveitis and a mature cataract?
I would like to start preoperative steroids, either topical or if the severity is more systemic steroid, keep the eye uninflamed and then plan for cataract surgery.
So how soon would you plan to do surgery for them?
At least 3 months of inactive disease.
Yes, exactly.
But since it's a mature cataract, can we wait for 3 months? Is my doubt.
I get what you're saying. Your concern is other complications, like lens related complications, like glaucoma and such. That's a good question. I don't know, but in the exam, I told him that I'd want it to be inactive for 3 months, and he seemed happy with that answer. And then he asked, how would you give the perioperative steroids? And I mean, you know, there are different ways that we can do that.
Can we answer that if it was only previously anterior uveitis, I would start the patient on topical steroids. And if there was posterior involvement, then I would start the patient on oral steroids, 1 mg per kg. Would it be sufficient?
1 milligram per kilogram. I think it depends on exactly what we're treating, because there are so many things that could cause posterior involvement as well. So I think it would be probably a multisystemic approach where we could include the rheumatologist in some cases, the infectious disease, because it could be infectious, it could be something inflammatory, right?
So was this, sorry, so was this
Yeah.
what you said, Dr. Valens, in the exam?
In the exam, I mentioned treating the inflammation. I mentioned topical, I mentioned systemic if needed. And then after that, when they're quiet for 3 months, then proceed with surgery and you give operative steroids. The honest truth is, I feel like in the exam you have to be very succinct with your answer because the time goes very quickly. So I feel like you can't go into as much depth. Like you probably know the topic in a lot of depth, but you don't have the time to tell them everything. But they know what they're looking for, and if you don't say something, they'll ask you for it.
Thank you so much.
All right. Okay, so then the next picture is something like this, and giving away the answer. So you know what this sign is, right?
Alt's line.
Arts line, yeah. So then ask me about how to manage trachoma and what surgery can you do. So go ahead. How would you manage trachoma? Because what I remember is the safe protocol, right?
Yes.
So how do we do the safe protocol? All right, what does acronym SAFE stand for? Okay, so you know the S is surgery, which is for patients who have advanced disease. And then the A is for antibiotics for the infection. F is facial cleanliness. And then E is to improve the patient's environment in order to reduce the risk of transmission, right? So what antibiotics would you give in the SAFE protocol?
It's either azithromycin 1 gram single dose, or you give erythromycin.
Yes, exactly. And then for the advanced cases, what kind of surgery can you do?
It would depend upon what the patient has. If it is entropion or ectropion, we need to correct it accordingly, I think.
Okay.
Trichiasis, if it is there, we need to treat that as well.
Okay, how do you treat the trichiasis?
Depending upon how severe it is.
Okay, let's say it is very severe. What's the WHO's recommendation?
We'll split the lamellae and do cryo to the posterior lamellae if it is so severe.
Well, what I had said was that you do the bilamellar tarsal rotation. And they seemed happy with that. But yeah, there are lots of different things that you could do. Agreed. But you have to tell them something. All right.
True.
Okay, so then they showed a patient with dacryocystitis. Well, obviously described the photo and came to that in the differential and how would you treat? So how would you treat a patient who has an acute dacryocystitis?
I will admit the patient for IV antibiotics. My antibiotic of choice would be IV augmentin, 1.2 gram TDS.
Mm-hmm. Okay, good. So let's say now the infection subsides. How are you going to manage them further?
I would further refer the patient for oculoplastic team to review. The patient can either undergo um, a endoscopic DCR or a or or a or a external dacryocystorhinostomy.
What's that? What's the last one you said?
DCR, dacryocystorhinostomy, right?
Oh, yes. So you said what? Either the internal or external approach?
Yes.
Yeah. Okay. Yes. So I said that pretty much. And then they showed me a picture that looked something like this. I think it was a basal cell carcinoma on the lower eyelid, but the time ran out. The time runs out very quickly. So then went to posterior segment and I was shown a picture, something like this. I think it was actually a lot more drusen than I've ever seen in a picture. Um, so we of course came to the diagnosis of age-related macular degeneration, and they asked about the treatments. So how would you treat the patient? How can you monitor them for conversion to wet AMD? And then how do you treat wet AMD? That's the question. So
For treatment of dry AMD, I would treat according to the AREDS 2 trial. So I'd give those
vitamins.
yes, vitamins.
What vitamins would you give?
It is zeaxanthin
Mm-hmm.
and also vitamin A
Mm-hmm.
and lutein as well
So I think lutein and zeaxanthin are supposed to be um,
together.
for the vitamin A,
Okay.
and then vitamin C and E,
Okay.
right? And then
Do we
zinc.
need to know the dosage of each vitamin, doctor?
I honestly don't know. In the exam, I doubt they're going to ask you the doses just based on how the exam goes because it's very fast. I don't think you have time to be sitting down and trying to think about the dose of each vitamin. I don't think it's bad to know, but I doubt they have time in the exam to ask you that. This is very fast. The time
Okay.
goes by very quickly. Um,
So how can you monitor for conversion to wet AMD? I would monitor the patient by doing a fundus photo during the fundus photo and ocular coherence tomography during each follow-up of the patient. And I would ask the patient to do self-monitoring at home with EMSLA chart, or they can do self-monitoring by looking at windows or the door, whether there's any metamorphopsia.
yes. Okay, good. So then, what if they develop wet AMD? How would you now treat them?
For treatment of wet AMD, the treatment of choice would be it would be anti-VEGF therapy now. So the anti-VEGF which is available currently is ranibizumab and also aflibercept according to the NICE protocol, NICE guidelines. I think we will use ranibizumab or aflibercept.
Yes. Okay, good. So after that, I feel like I was at this station for a while. Hello?
Yeah, I mean, did they ask about trails?
No, they didn't ask about trials at all. I think for the whole
No.
exam, we never mentioned even one trial.
Okay, that's good to hear.
That doesn't mean that they might not ask you about one, but
True.
they
Very
never
true.
asked me about any trials. Even even though I studied for them, not even one trial. But I guess to some degree, we're still sort of discussing trials because the management of things is determined by the trials. So even though they didn't ask me to tell them about the trial, like even the treatment of wet AMD, that is also based on a lot of different trials, but they didn't ask about a specific one. Okay, so then they showed me some sort of picture like this, and the time ran out, so I don't know what they were going to ask me. It looked like a Coates disease case to me. And then we were on to glaucoma, and they showed me a picture of anterior. What's that? Yes, so they showed me an anterior segment photo with a shallow anterior chamber and asked me to describe it. And then they asked me about how you treat a patient who has acute angle closure. So how would you treat a patient with acute angle closure?
Um, it depends on the corneal clarity. If the cornea is hazy and the IOP is very high, I would initially give the patient systemic anti-glaucoma agents such as IV Dimox 500 mg stat, and if the IOP goes down and the corneal clarity improves, I would do a argon laser peripheral iridotomy for the patient. But however, if the IOP doesn't come down and the cornea is still hazy, I might need to start the patient on other systemic anti-glaucoma such as IV mannitol, or I can give the patient IV glycerol as well. And if the cornea is still hazy, I can attempt to do a argon laser iridoplasty first. Then once the cornea is clearer, I would attempt for argon laser peripheral iridotomy. And for future, I might even list the patient for early cataract surgery.
Yes. All right, so that sounds like what I said in the exam pretty much. So then the next picture is like this, and they asked me to once again describe what I saw. And then if the patient has a raised intraocular pressure, how can you treat it?
This looks like neovascular glaucoma. So it again depends on the vision of the patients. The main treatment would be for if there is fundus view for pan-retinal photocoagulation. If there is no fundus view, we can attempt an anterior retinal cryotherapy. If the neovascularization doesn't seem to reduce and the IUP is still high with maximum anti-glaucoma, and also if it is still high with maximum anti-glaucoma, I would suggest the patient for either laser such as TSCPC if his vision was poor, and if the vision was not poor, I would suggest for a glaucoma drainage device.
Yes. Okay. Good. And then they showed me a picture somewhat like this, and asked how would you rule out glaucoma in a patient like this? So pretty much what investigations would you do?
So
If
First, I'll check the intraocular pressure in
Mm-hmm.
both the eyes, and
Yeah.
and also because there is asymmetry of the disc cupping. I mean, I'll do all the glaucoma investigations like intraocular pressure, gonioscopy, and central corneal thickness as well. I'll also know the patient's family history if there is any glaucoma associated history in his family, and I'll consider the age of the patient. If it is more than 40, or if there is any family history, and if the IOP is more, then I will do all the glaucoma investigations like OCT and OCT of
What
the optic disc.
OCT?
Optic of the optic disc
Mm-hmm.
and
Is there any other
retinal nerve fiber
OCT that you could also do?
macular
Mm-hmm. So to look at the ganglion cell
to look at
complex.
the RNFL, yeah, and ganglion cell complex.
Yeah.
Yeah, I will check the visual fields
Yeah.
as well.
Mm-hmm.
Yeah.
Okay. Yeah, I think that was pretty much it. And then there's some sort of question about a patient hammering a nail that they started telling me about. There was no picture, it was just some sort of scenario, and the bell rang. So I think that was it for my oral exam. So then 2 days later, I had to go to this place, Research Institute of Ophthalmology, for the clinical exam. Now, you know that for the clinical exam, you're not supposed to wear anything below your elbow. So no watch, no long sleeve shirt, because I think it's the NHS guidelines, because you're actually going to be interacting with patients. But this went by very quickly as well. Honestly, the moment you go in the exam, you feel like the exam is done because the time runs out very fast. So this is the first case that they showed me. It was a relatively young looking girl, probably a teenager, and it looked just like this. So you can see that there's ectopia lentis with superior temporal displacement of the lenses in both eyes. And they asked me to show them how I do retroillumination. So I did. And they asked me, what are my differentials? So what are your differentials for this patient with ectopia lentis?
It's
sorry.
it's Marfan syndrome, homocystinuria, Ehlers-Danlos,
Wheel Marchesiani.
Wilmats.
Yeah. Okay. So then they asked me how to manage this patient.
So we'll check the vision and go for if it is, I mean, if we can manage with glasses, we have to think in lines of that, or we can go for a cataract removal with the help of VR surgery and tension rings, that capsular tension rings, with the help
Yeah.
of capsular in rings, but because I think the subluxation is more than 270 degrees, I think we can go for a scleral fixated intraocular lens with the help of a vitreoretinal surgeon.
Yeah, agreed. So then, what systemic associations could the patient have? Because it's a patient that had a marfanoid habitus. So I really thought that they had marfans. They even let me look at the patient away from the slit lamp. So what other associations are you worried about in the patient with Marfan syndrome?
We should refer this patient to cardiologist,
Yeah,
and we should check if there is glaucoma or not, because
agreed.
such patient can have pupillary glaucoma.
Yes. All right, good. So then the next case looked just like this. And when you ask the patient to look down, you see that there's a bleb there. Honestly, it looked like it was a failing bleb and avascular. And then they ask, what do you think happened to this patient? So, of course, think that this is a patient that has pseudo exfoliation glaucoma and had a trabeculectomy. So in a patient like this, what are the possible complications of cataract surgery? Is the question.
They will have poorly dilating pupil and the zonular dehiscence. So there is a high possibility for a posterior capsular rupture, which might need so for the small pupil, we might need we might need iris hooks for the surgery, or we might need to dilate the patient with adrenaline. We can try to dilate the pupil with viscoelastic as well. And if there is posterior capsular rupture, if it is a small posterior capsular rupture, we can insert a sulcus IOL intraocular lens. But if it is large, then we might need to insert an anterior chamber intraocular lens. For the zonular dehiscence, the patient might need a capsular tension ring according to the degree of the zonular dehiscence.
Yeah. But the thing about these patients is that the zonular dehiscence can even happen years after the surgery. So I think I would probably put a capsular tension ring anyway, especially one with eyelets, so that if it happens down the line, you can still fixate it.
Okay,
But
thank you.
yeah, man, no problem. Okay, so I think that was it for the anterior segment. In each station, they actually have 3 patients, but you often don't get to the third one. I guess it depends on how quickly you go through the first 2, whether you see the third one. But it apparently doesn't really matter. It's more the quality of your answer than the quantity in the clinical exam, I think. So this was the next station. So posterior segment, and it looks really something like this. So disc is pale, the vessels are attenuated. Obviously, the patient had some sort of vascular occlusion in the past, but it wasn't recent. So came to the conclusion that was actually a central retinal artery occlusion that the patient had had. I don't even remember what the questions they asked me after that. My mind is blank as to whatever else they asked me about this patient. But then the next patient. So they showed me a patient who obviously had bilateral diabetic retinopathy, severe non-proliferative. And then in one of the eyes, there was a dilated tortuous superior temporal vein. So actually this was a BIO examination. So that kind of surprised me. I think they can give you slit lamp, they can give you the BIO, they can even give you a direct ophthalmoscope. Because one of my colleagues who did the exam in Bangalore, she actually had to use a direct ophthalmoscope in the exam. So I guess be prepared for anything. But there was a patient with a bilateral non-proliferative diabetic retinopathy, and in one of the eyes had a superior temporal branch retinal vein occlusion. And that was it for posterior segment. So then we were on to neuro-ophthalmology. So eye findings were something like this for the patient. But it was a boy, I think like adolescent, and they asked what the diagnosis was. So pretty much abduction was maintained, and eye movements in the other directions were decreased to almost nothing. So then, what are the possible causes of a cranial nerve free palsy?
It can either be, it can be divided into medical or surgical causes. The medical causes, it can be poorly controlled systemic disease such as diabetes mellitus or hypertension or dyslipidemia. For the surgical causes, it is usually posterior communicating artery aneurysm. So in this picture, there seems to be anisocoria. Most probably, it is a surgical third nerve palsy.
Yeah. So the patient that they actually showed me in the exam didn't have anisocoria, but they just asked for the differentials in terms of cause, and then that was it for that case. So then the next case.
Excuse me, sir.
Yes?
Excuse me,
Hello?
sir.
Yes.
Did they ask, since the patient is there, did they ask you to examine anything? Like, did they ask you to do the ocular movements or
Oh,
any
yes.
other?
Sorry, I didn't mention that. Yes, I had to do the extraocular movements for the patient and comment on the pupil size, comment on the eyelid, and then after that, I had to tell them what I thought the diagnosis was, and then he asked me what the possible causes were. So yes, he had to examine the patient first.
Okay, sir. Thank you so much.
Yeah, no problem. Honestly, I think a lot of the videos in the group that Gada was posting and that you guys were doing were very helpful. But yes, you had to examine the patient. So this was another patient I had to examine. Not this exact one, but something like this. This was a gentleman, probably a middle-aged gentleman, that I had to examine his extraocular movement. So what do you notice?
I can see there is defective elevation in adduction in the right eye.
Okay.
So could be a Brown syndrome.
Yes. Good. So it was a Brown syndrome. So then how would you treat a patient with a Brown syndrome? First of all, would you treat all of them?
No, that is for sure. Will not treat
All the Brown
all the Brown syndrome because
The patient might not be symptomatic most of the times. So
Yeah.
till 14 years of age or something, we can wait.
Yeah, exactly. So you can have acquired or congenital, but both of them can spontaneously resolve. So most of them, the majority of them don't actually require treatment. But what if you needed to treat them for some reason? What are the options? So it depends on the cause, right? So you have some inflammatory causes in which you might do something like injection of steroids to the area of the trochlea, or you might, in some cases, want to give systemic steroids. But what if you needed to do some sort of surgical intervention? So I know that there are a lot of different surgical techniques, and and honestly, I just had said um, to surgery to elongate the superior oblique tendon, and he immediately moved on to the next patient because I mean I was going to continue, but he showed me the next patient, and it was a little girl who had a relative afferent pupillary defect and just asked about the possible causes, and the bell rang, and that was it for the neuroophthalmology part of the examination. So then the next thing was oculoplastics. So between each of them, you go outside for, I don't know, it feels like about 30 seconds, and then move to the next station. So go in and have a patient like this. So honestly, they just tell you to examine the patient. You can do whatever you want to do in terms of examination, and they have all the equipment there that you might need. So how would you examine this gentleman? What would you want to do?
I would examine the visual acuity intraocular. For the ocular examination, I would examine the visual acuity, intraocular pressure on front gaze and up gaze. I would also examine the extraocular movement, and I will check. I will examine for proptosis with the Hertel's exophthalmometer. Other than that, I would also look for superior limbic keratoconjunctivitis, any caruncle swelling, any conjunctival chemosis or conjunctival injection, any pain on eye movement. For the systemic examination, I would look for goiter, um, whether there's any presence of neck swelling, whether there's goiter, then whether there is any fine tremors, whether the patient has dry skin. I guess that would be it for the systemic.
There are a couple others. There's actually thyroid acropathy, the finding in the nails similar to clubbing, and pretibial myxedema. And you
Okay.
mentioned the tachycardia with a high volume bounding pulse, right?
Yeah.
Yes, but we never really got into the systemic because they wanted me to examine the patient, and when I started mentioning systemic things, they told me to stick to the eyes. So they didn't want me to do all of that.
Okay.
So then they wanted me to examine him with the Hertel, and I did. And then they pointed out on the Hertel the markings for the outer intercanthal distance. So what is the purpose? Sure, of course.
The outer intercanthal distance is the base value while we are measuring the exophthalmometer. It usually is not going to change even though the proptosis is going to vary. So that is kept as a standard value so that it helps us to measure. The followability and repeatability can be assessed because that is the standard value. So even in the follow-up visits, we can assess as per that intercanthal distance.
Yes,
Is-
exactly. Okay. So then the next case. Now, honestly, I think at this point, I don't know if I was tired or what, but they showed me a gentleman who had a bilateral ptosis, but it wasn't a very severe ptosis. It's not quite like this picture. It was pretty symmetric, and I was looking at him for a while before I realized that he had a bilateral ptosis. I don't know how long I was there. It was a bit embarrassing when I realized what it was actually. Um, so it's a bilateral ptosis, and then this is it. I don't know if they had any follow-up questions prepared because it was just about examining the patient. So went through all the different measurements while they watched me, and that was it for him. They didn't ask me any other questions. Maybe it's because I ran out the time trying to figure out what was wrong with him in the beginning.
Dr. Wellens, since this is a neuro-ophthalmology station, is it possible that the patient could had myasthenia gravis, and we need to try to do the lead fatigability test, Cogan lead twitch, and also examine the extraocular movements as well?
Yes. The honest truth is, I had mentioned some of those, but they didn't actually want me to do that. I think they just wanted to see me do the measurements, but it could have been myasthenia. They didn't want me to do any extraocular movements. That was just, I think it's just whatever they want to see. I think they have some sort of a rubric and they decide what what they want you to say, what they want you to do, and they grade you based on that. So all of those things would be suitable for that patient. I agree, but I think they just didn't want it.
Oh, okay. So they guided you to do these examinations instead. Like
Yes,
they ask you what else would you do? Is it?
yes, exactly. They ask you what else would you do, and then they tell you whether you should go ahead and do it.
Okay, okay. Thank you, doctor.
Yes. So I think that was
Excuse
it.
me, Dr. Valence. I had
Yeah.
a doubt regarding this. So initially, as soon as you walked in, what do they initially ask? Do they tell you like do extraocular movement of this patient, or they just ask you to inspect and carry on with your examination, and then they stop you in between?
It varied from patient to patient. Sometimes they were very specific. Like for instance, let's see, it was the patient with the pseudo exfoliation. They asked me to do a slit lamp examination of the patient's whichever eye it was, right eye or left eye, and they were very specific. But in some of the other stations, like the one with the thyroid associated orbitopathy, they just said examine the patient. So it varied. Sometimes they were very specific, sometimes they were vague. It was just examine the patient. So um, I don't think you can predict exactly how they're going to ask you in each station. It varies.
Okay, so and for slit lamp or fundus examination, do they tell you like to stick to one eye, and do you need to ask permission to examine the other eye?
Um, so as I said, for the pseudo exfoliation patient, it was one eye that they wanted me to examine, and they told me to just examine that eye. So I did exactly what they told me to do. For the other patient that had the diabetic retinopathy, they wanted me to look at both eyes with the indirect ophthalmoscope. So they told me that. So I think they'll tell you what they want you to do. Honestly, I just followed their instructions. So if they told me to examine the right eye, I'd examine the right eye. And then, I mean, I could say I would also like to examine the left eye. And then they would say no and ask me some other question. But if they said to examine both eyes, then I'd examine both of them. So I just followed their instructions, to be honest. And I just answered exactly what they asked me.
Okay, thank you,
Because,
Dr. Allen.
yeah, man, no problem. Obviously,
I
they know
had one more doubt.
What's that?
I have one more doubt. So in the diabetic retinopathy case, that patient had both a diabetic retinopathy as well as a BRVO.
Yes. They had diabetic retinopathy in both eyes and a BRVO in one of the eyes.
Thank you so much.
It was actually kind of surprising. Like I saw it, I mentioned the diabetic retinopathy, and then they asked me if there's anything else that I saw in one of the eyes. Because it was a bit surprising, but it was a double pathology.
Doctor, what did you carry along with you, like apart from the torch and all?
I didn't carry anything because they have everything there. You can carry things if you want to,
Okay,
but I didn't even have a torch. I just left my bag with them and went in with my two bare hands, and they had all the equipment. So you don't really have to worry that you're not going to have anything. So if you're gonna what's that?
No, please go ahead, sir.
No, I was saying if you're examining at the slit lamp, then they have lenses there for you to examine with. They'd have like a 90D, 78, or whatever, and you choose what lens you want. So there was never a case where they wanted me to do something and I didn't have what I needed. They provided all of it. They also have hand sanitizer there for you to use at the beginning and in between patients. I forgot to mention that. So I think that's also important, that in between cases you use their hand sanitizer or wash your hands.
So when it comes to the RAPD question,
Yes.
did they ask you to do the swinging flashlight test? Or if yes, did you dim the room light? And how did you do that test, sir?
Yes. So with the RAPD question, it was a little girl. She wasn't the most cooperative, but yes, I asked them to dim the room light. They just asked me to examine her pupils. So dim the room light, and then when I did the swinging flashlight test, I realized that she had a relative afferent pupillary defect. And then they asked me what are the possible causes.
So you started with direct light reflex first, then consensual, and then you
Yes.
did this flashlight test, right? Yes.
Yes, exactly.
Okay, sir.
But as I tell you, she wasn't very cooperative. She was probably getting tired because, you know, they have a lot of candidates, and she looked like she couldn't have been more than about 8.
Excuse me, doctor.
Yes.
Regarding the case with the pale optic disc with sclerotic retinal vessels, what was the diagnosis or what was the scenario exactly?
No, so apparently, because I initially wasn't even certain, I was giving them a list of differentials, but it's apparently a patient that had an old central retinal artery occlusion.
Okay.
And I don't remember what else they asked me about that case, because when I looked at it initially, I wasn't certain what it was. So I described what I saw, and then I started giving them differentials. And when I eventually said that it could have been a central retinal artery occlusion, then they asked me something else, but I don't remember what.
Okay, thank you.
You're
So
welcome.
coming to the third nerve palsy case, sir.
Yes.
So if the patient you got is a young patient, is what you said, right?
Yes.
Third nerve. So when they asked you the causes, did you tell which are related to that young person only, or did you tell all the causes like ischemic causes and all? Like, how
No.
did you go with that case?
Well, I think it depends on exactly how they word the question, but I think they actually had asked me what could have caused it in this patient. So I tried to just say the ones that were relevant for his age group.
So probably trauma would be one cause. No, sir. What else did you say?
Yes.
Like trauma.
Honestly, I don't exactly remember everything that I said.
Okay, sir.
But I do remember that I tried to keep it relevant to him because of his age. So it's unlikely to be a microvascular, for instance. But I guess it could also be compressive. It could be a tumor. Unlikely to be an aneurysm, but I guess it's possible.
Okay, sir.
Yeah.
Dr. Valens, I just have one doubt. If you said there was one station where they expected you to do indirect ophthalmoscopy, right? Did they ask that? I mean, how did you do it? Did you make the patient lie down, or did you do it with him sitting up?
Okay. They told me to do it with the patient sitting up. The patient was already sitting up, and they told me to examine her while sitting up. And they also didn't want me to look into the periphery. So when I started doing that, then they told me, no, don't do that. So
Sure.
so they tell you exactly what to do. Honestly, I don't think you're going to have any doubt in the exam as to what to do, because they tell you exactly what to do.
Thanks a lot. Thanks a lot.
No
Did you
problem.
dim the room light during the SIO examination, sir, or it's not necessary?
During which examination?
Indirect, sir. Indirect
Yes.
ophthalmoscopy.
I think that they actually had dimmed the room light for the whole posterior segment examination part.
Okay,
Actually,
sir.
no. They asked me if I wanted the lights off, and I told them yes. So they help you. They help you a lot in the exam. Honestly, I think the examiners are very helpful. At least the examiners that I had, I thought were extremely helpful, and the instructions were very clear. So I don't think that's something you have to worry about.
For the last case, ptosis, you examined it for both the eyes, sir? Because it looks like bilateral ptosis, right? So even in the right eye, there is mild.
It was bilateral. I'm trying to remember. I think I did. I think I had examined both eyes, but I'm not 100% sure. It's either I examined both or I examined one, and when I went to the other, they told me not to do it, but to move on. I don't remember though. I think I
So
may
you
have
know.
examined both.
Okay, so you have noted all the measurements on a paper, sir. Did they provide that?
I don't think they really cared for me to write down the things, so I
Okay.
hadn't. I think in that station they just wanted to see my technique. I think that was what it was about. Just looking at the technique for examination of the patients.
Okay, sir.
But as I tell you, it took a while for me to realize that there was a ptosis, because it wasn't a very severe ptosis. So it was a bit embarrassing. I was there trying to figure out what it was. And then I realized that it was a ptosis. That was what they asked me to do. So I don't know if they had other follow-up questions.
Just one last question, Dr. Valens. If in the orals, right, when they just showed you photographs, do you like start describing the whole thing, or you just start off with the diagnosis? What did you do?
No, start describing what you see, and then give the differential diagnosis. A lot of them, I think the diagnosis was pretty obvious from the picture, but yes, describe it first, and then give a differential diagnosis.
Sure.
And then
Thank
they will continue from there when you say the diagnosis that they want.
Got it. Got it. Thank you.
Dr. Valence, I had one more doubt.
Yes.
In your Viva, like in the oral exam, do you have to just only stick to the point? Suppose they ask you management, will you stay from starting? I will ask history and examine the patient, and then investigations, and then come to the treatment, or will you directly go to the treatment?
When they asked me about the management, I mentioned the history briefly. I mentioned the history and the examination because, well, I was taught in my university that that's a part of the management of the patient. So I always mention the history and examination, but I don't think you have time to go in detail into any of it. I think it's really the main points because, as I tell you, the exam goes by very quickly, and you don't want to be left saying things that are not relevant to the examiner. Although I think if you went on a tangent, they would tell you to come back, you know? It's the kind of exam where if they ask you the management and you start talking about the history for a long time, they would tell you to stop talking about that and to tell them how you'd manage, if you get what I mean.
Okay, thank you so much, Dr. Valence.
No problem. I think that the examiners are very good and that they keep you focused on the answers that they want. And if you go astray, then they will let you know that you're going astray and you're not gaining any marks or whatever. All right. Any other questions? No?
No, thank you so much, sir. You
No
are so
problem.
you are so kind to answer all our silly questions. Really.
No, they're not silly questions. You don't know what to expect. So I think it's good to talk to someone who's been through it, who can give you an idea of what to expect when you go. But I honestly think that you'll be fine because they're very kind.
That's really great. Thank you
Yeah.
so much, Dr. Valence. It
Thank you
was
so
really
much,
kind
sir.
of you to spend so much time with us.
No, that's fine. I'm happy to. So then after the exam, I got to see a little bit of Egypt. So, rode a camel. I saw some pyramids. I went into the Great Pyramid of Giza. But
Amazing.
yeah, I mean, I don't know if I'll ever go back to Egypt again. So I had to take the opportunity to go around a bit. But I only
Absolutely.
had a couple of days. But these are the books that I used. So Kamsky, honestly, I feel like any question that they asked, the answer was in Kamsky. I don't think they asked me anything apart from the medicine station. Honestly, only the seizure question. I think that's the only question that the answer is not in Kamsky. So yeah, I think if you know Kamsky, you'll be good. The second book, the Ophthalmology Oral Board Review, is something that I went through with one of my colleagues just to practice talking. So she just asked me the question and I just answer as best as I could out of my head. Mostly information I'd gotten from Kamsky, but just to practice. And of course, in the clinic, I was also practicing if there was any patient that had any neurological finding or anything like that. And then I think that this book is extremely good for the medicine part, Oxford Handbook of Acute Medicine, because it's to the point. It gives you the points on how to manage things. I mean, there's going to be a lot in there that isn't really relevant to the exam. So I kind of just thought of what topics I thought were most likely to come, and I looked at them in this book and I made some notes and I reviewed them the morning of the oral exam because, you know, it's not my strong point, and I was really worried about the medicine station, and it wasn't that bad. Maybe I was just lucky that I got seizures and it was one of the medicine topics that I had prepared for, but it wasn't that bad. It was honestly in the oral, I feel like the medicine station might have been one of my best stations. I know that sounds weird. And then I don't know if you guys know Anki, but when I was going through Can Sketch, they made some flashcards in Anki, and I used those to revise as well. You know, spaced repetition. Yeah. So in terms of the exam, I have learned that you don't have to know everything to pass, because I didn't know everything myself, and I was actually a bit concerned that I wasn't going to pass. But I tend to be hard on myself as well. So that might be a part of it as well. But the examiners, they're very kind and they're very helpful. I don't know if that's how they are in every exam, but I know in my exam that they were very kind and helpful. And I mean, they're not really giving you any hints as to whether you're doing well or you're doing terribly, but if you're not answering what they want, then they'll let you know so that you can change your course of answer. And as I tell you, the exam is very fast. It goes by very quickly. So when they ask you a question, I think answer exactly what they ask you. Don't go off on a tangent, or you're just losing time and you're not answering as many questions as you could. And I think it's good to practice speaking and practice examining patients, because under pressure, that's what's going to help you, because it is a lot of pressure when you're in the exam. All right, so that's pretty much my experience. So if anyone has any other questions, I'll answer them. But otherwise, that's all I have.
Hello, sir.
Yes?
Sorry to ask at this point. Actually, I wanted to ask a question. In the ocular motility station, sir, did you do any cover uncover test at for any of the case? Were you asked to do directly, or did you do by your own? Is it a part of we are supposed to do?
The ocular motility. Let me see. Because I had the cranial nerve 3 palsy, I didn't. On the Brown syndrome, I didn't. I don't know if they wanted me to, but I felt like after doing the extraocular movements, I already knew what the diagnosis was, so I didn't. I don't know if I should have. So
Okay, sir.
I don't know if Prof. Muthusami or somebody more senior can answer that question.
For the Brown syndrome patient, how did they ask you? So, like, did they ask you to directly do the ocular movements, or you started with Hirschberg's test? Then, like, how did that question go, sir?
I think they had asked me to examine the extraocular movement. I think they directly asked me in that station to examine the extraocular movement.
Okay, sir.
Yes.
Valence, can you hear me?
Yes. Yes, I can hear you.
This presentation was excellent.
Thank you.
Now, I want to ask the students, what did they learn from you listening to you today? Anybody?
So this is Hasika, sir. After this
Yes.
presentation, I understood that examiners are they are helpful. So we should not be under so much stress, because they always try to help us. That is one thing. And with this,
wait, let me let me answer. Wait, let me. You know,
yes.
When the examiners are asked to train, because I'm encouraging a lot of people who have become examiners.
Okay, sir.
one of the things that they're told is your purpose is to pass these students.
Okay.
Do you know that?
Yes. Sir.
So the examiners are there to pass you.
Yes. Sir.
A lot of times, because I had been with the examiner many years, from
Yes, sir.
1978, a lot of people will come and tell you that they so unfairly failed you. You
Yes.
know, Amar failed his exam. Well, do you remember his presentation? He was so very honest. When they asked him question about nystagmus, he didn't know anything. He did the exam, the rest well. The examiner simply can't pass an exam, a student who does not know anything. You follow that? The examiners are there to help you to pass. Remember that. When you go with this, we will be much braver. Am I right, Valence?
Yes, I agree.
Then you see, at one point, they didn't ask him any question. You know, was there two examiners at the same time, Valence?
Um, in the clinical exam, I think you have two examiners and then one or two observers.
Okay. You know what? They look at everything that you do. The technique. If you can do the technique alone properly, they won't ask you any questions. You pass. And then somebody was mentioning the vitamin. Vitamin was given to all of you by me. They are not interested in you vomiting the vitamin. They want to know whether that particular patient has got this or not everything that's in the vitamin. You follow? It is that
Yes.
patient that you are seeing at that examination. Concentrate on that patient. And you will be okay. Isn't it? When there was a question that I think Valence was saying, that's Marfan's syndrome. They asked you to come out of the slit lamp and examine the patient.
Yes.
Once they ask you to examine the whole patient, you don't talk about the lens anymore. You follow? If it kept on talking about the lens, you might have thought that you have done extremely well. They might even fail you. Because simply you did not follow the instruction. Very simple. They said, come out of the slit lamp and examine the patient. What do they want? They want you to give you the systemic manifestation of muffins. Am I right?
Yes.
And if I have not described that, should they pass you?
No.
Simple as that. I say, I have made a note of what Valence was saying. They only want, they only tell you, they want to tell you what they want to hear. You know that? I say, if there's a case with this particular symptoms or signs, they expect you to tell that, not what you want to give into 1 to that, 1 to 10 or A to Z. Okay? Valence, we have actually, this is one of the best presentation by people who have passed this examination. Thank you, Valence. They should have learned a lot of, and you have put everything there. The lessons learned, everything is there. And I repeatedly say, study your Kansky, study your Kansky, study your Kansky. And what does Valence say? Valence also says the same thing. Am I right?
Yes, definitely. Thank you, Professor.
And some of you might be very biased. Why I recommend what do you call Kansky and Parsons. Does any one of you at the meeting ever read Parsons? Is there anyone? Anyone from India?
Yes, sir. I read during my post graduation. I read only Parsons. I read Parsons.
What's the difference between Parsons and Kansky?
And during my
Pardon?
this
Pardon?
Difference
Do
between
you know what's common? What is common about Kansky and Parsons? Any idea? You'd be very
No.
surprised when I tell you this. None of you know. I'm telling you
The
today.
it seems to be simplified compared to, and it's concise compared to
No, my
Kansky.
question is, what's the common factor between these two? You won't know. Did you see the name Radhika Tandon there?
Yes, sir. Yes.
Did you see Brett Bowling? Brett Bowling. You see well as what do you call it? Kansky there. That big name there, Brett Bowling.
Yes, that's true.
Both of them are recipients of my medal. Are you aware of the Muthuswamy medal?
Yes, sir.
Look at them, both of them. All the people who have won my medal have become here and there world famous. The big shots. If you're in Madras, there's one Srinivasan. Do you know the cornea man Srinivasan? Anybody? Okay, let me not go into them. Pardon?
Madurai, sir. M. Srinivasan, sir.
No. He's in Chennai.
Okay, sir. I don't know, sir.
Okay, there are a few. That's why I've written things here. All those things. Everything that I have written here, Balance has covered very well. What I want you to do is, all of you, before you go for the examination, please see this recording again. All of you can get this recording, isn't it?
Yes, I've recorded it.
Yes, and you please make it available. I think Professor Gada is there. Gada, are you there? Gada? Okay. Anyway, all this stuff, you please make sure that the recording is available to everybody. Balance.
I will do that.
Okay, you will do. You know why? This will be very, very useful. I want all of you to please go through this recording at least once, 1 week before the examination. Please, it will be very useful to you. Okay. Now, is there any questions that you want to ask Valence again? Hello?
No, sir. No, sir.
Everyone
I
has
have
got
one
yes.
last doubt to Dr. Valence, sir.
Sure.
When you are, sir, Dr. Valence, when you are examining with exophthalmometer or any other thing, did you talk to the patient like, I'm going to place this on your eye? Can we do that, or are we not supposed to talk to the patient? And when examining a Marfan syndrome patient, did you ask him to stand, or did you talk to the patient by any chance?
Just
Yes,
hold on. Valence, I will ask you. What would you do when you're in the clinic?
I will definitely talk to the patient, sir, but
Then how anything that you do in the clinical examination, please do
okay.
what you do in your clinic. You'll never go wrong.
Okay, sir.
Am I right? Am I right, Valence?
I agree. The only thing is that they tell you not to ask the patient for permission to examine them, but otherwise, yes, pretty much. I was just talking to them like I was in the clinic.
Yeah.
Okay, sir. Thank you so much.
Okay. Any other question? Any other question to Valence, please? Valence, thank you very, very much. You made the day for the students. I was a little worried that today there will not be any meeting. Thank you. Thank you very much, Valence.
All right. Thank you very much, Professor Muthuswamy.
Shall we close the meeting?
Yes, sir. Thank you, Muthu, sir, and thank you, Dr. Valence. Wonderful.
Thank you. Good night.
Thank you so much.
All right. Thank you.
It's good morning in my country, you know.
Oh, hey, it's good morning
Good
here
morning.
as
Good
well.
morning. Good
Good
morning.
morning to you.
Bye.
All right. Bye.
Thank you, sir.
Bye.
Bye.